So the topic here today was management of urinary tract infections, specifically recurrent infections, which are a feature of diabetes. So if we look at the clinical symptoms that we face when we look at urinary tract infections in diabetes, we have bacterial infections, viral, not so common. Of course, there's genital tuberculosis, like every other condition. In diabetics, it is more common and is a particular feature in India. Among the bacterial infection, perhaps the most common is this asymptomatic bacteria. And every one of us would at some time have faced this patient, asymptomatic, but always has pyonuria, always has a positive culture. You treat with sensitive antibiotics, the culture becomes negative and becomes positive again sometime later. Should these patients be treated? As I run through, I'll look at what is available and what we should do. There are conditions like emphysematous pyelonephritis which are peculiar to diabetics, and these are representing xanthopyelonephritis and pyelonephritis and malakopractia, all of which are common in diabetics. What is the problem of urinary tract infection in diabetics? There is a 5-fold higher incidence of pyelonephritis in diabetics. When you look at men with good glucose control, asymptomatic bacteremia is about as common as in non-diabetics, but it is 2 to 4-fold higher in women even with good glucose control if they are diabetic. The estimate of asymptomatic bacteria may be as much as 1/4 of all diabetic patients. The susceptibility increases with the vintage of diabetes, and the incidence rate of UTI is about twice that of non-diabetics when we look at 1,000 patient years. It is highest in women being about 91 per 1,000 patient years as opposed to men where it is about 28. And in a cumulative look at diabetics, about 2% of them, and that's a huge number considering the diabetic population, will have an episode of urinary tract infection during a period of 6 months. Type 2 diabetes is a risk factor for every type of urinary tract infection, whether it is community acquired, nosocomial, post-transplant, and it is also a significant risk factor for fungal UTIs. Interestingly, there was in 2 studies when type 1 diabetic children were considered, neither boys nor girls with type 1 diabetes had a higher incidence of infections, either bacterial or fungal, than their non-diabetic counterparts. And also, it's important to realize that in this era, as we are dealing with more and more resistant pathogens, the diabetic is more prone to resistant, multi-drug resistant uropathogens. Extended spectrum beta-lactamase positive, most of all E. coli and Klebsiella, fluoroquinolones, which are the mainstay of our treatment, many are resistant to that. And in the Western world, vancomycin resistant enterococci. Is there data from India? I found two studies, and this is after data from David Hospital. In 2016 December, what we faced is about 20%, 1/5 of all E. coli and Klebsiella are resistant even to carbapenems. Look at fluoroquinolones. Only 15% in our study, and in another study published in 2016 by 10% of bacteria only which cause UTI are sensitive to fluoroquinolones. The rest are resistant. When we look at cephalosporins, it's about 30 to 40%. And that is why we are increasingly looking at treating complicated infections, urinary tract diabetes, with only these 2 drugs, colistin and ticagrelor. So, fortunately for us in our data, what we found is that when we looked at OPD-based cultures, 95% of diabetics with uropathogens were still sensitive to nitrofurantoin, and among Indo patients, about 3/4 were still sensitive to a third-generation cephalosporin beta-lactamase inhibitor. But other studies weren't as encouraging. Why do diabetics get more UTI? Well, hypoglycemia per se causes neutrophil dysfunction, monocyte dysfunction, altered immune function, the immune response is poor. There's ketoacidosis which predisposes patients to need more UTI. This is interesting because the use of the flogins, cannabinoid and dapagliflozin, have led to a small but significant increase in urinary tract infections, especially in patients whose diabetes was not controlled when the SGLT2 inhibitors were started. Now, this may be because there is a slight increase in the amount, there's a significant increase actually, in the amount of glucose urea that takes place when this class of agents are used, and and that may have led to a better milieu for bacterial growth in the urinary tract. What are the factors that predispose to a patient getting a recurrent UTI? If I can convince you of two of these over here, it will be good enough. The most important from my mind is a condition called diabetic cystopathy, and I'll show you some of our own data on that. The other significant feature is that calculi in diabetic patients, many diabetic patients will also have hyperuricemia, which predisposes them to calculi with uric acid. And these patients, the calculi are frequently infected. Vascular insufficiency, papillary necrosis, and especially emerging papillary necrosis leaves an area which is poorly perfused, which is necrotic, and favors not only the growth but the persistence of bacteria in an area where antibiotics do not penetrate, and may result in recurrent infection. And then, of course, there are all the others, foreign bodies, contact anomalies, etc. It's important this sentence comes from the Infectious Disease Society. It says, in a diabetic, every urinary tract infection should be considered complicated, as opposed to the otherwise definition that complicated UTIs are only considered those in which there is an anatomic abnormality. Diabetic cystopathy and its contribution to UTI. A student of mine and I studied 27 consecutive patients between 2004 and 2006. We screened them all by neurological examination, history, ultrasonography, and creatinine clearance, and we confirmed the presence of cystopathy by hemodynamic evaluation. This is what we found among the 27. 25 of the 27 patients were type 2 diabetics. The duration of diabetes at the time of detection of cystopathy was long, about 15 years on average. Diabetes was not very well controlled. There was nephropathy with a raised creatinine, and 4 of these patients were dialysis dependent at admission, and 8 of them had already had recurrent infection. Retinopathy was present in 18, nephropathy in 18, and neuropathy in 20 of the 27. Macrovascular disease was found in 12 of the 27. Retinopathy, as I said earlier. 6 patients had voiding problems, 3 had incontinence, and 3 had retention. Sensory motor neuropathy was found in 10 of them, isolated saccharine segments. The rest of the CNS examination would be normal in 5 of these 10, and a completely normal neurological examination in 4. Autonomic neuropathy we found by testing in 10. The symptoms: 8 had cystitis, 4 of which were recurrent, and 3 had emphysematous pyelonephritis. When we looked at urodynamics, proprioception was found in almost half of these patients. Another 1/4 had mixed vision, sensory and motor, and pure motor in another 30% more. These patients were all provided with continuous catheter drainage, and we found a significant improvement post-drainage in 17 out of the 27 patients, with even the GFRs improving by about 50%. So that is the contribution that we have found of diabetic cystopathy, and I think that is one condition that I would always like to evaluate, rule out, and treat in a diabetic urinary tract infection. Passing on to some of the specific infections in diabetics, perhaps the most feared is emphysematous pyelonephritis, and 90% of these infections occur in diabetics. They are caused by high virulence organisms, E. coli, Klebsiella, Proteus, Pseudomonas, and in some cases Candida. There is a severe necrotizing infection. Mortality is 60% when confined to the kidney. These are old figures. The mortality, as I showed you, is much better now. And 80% if there is systemic involvement. The mean age is around 55 years. Fever is seen in almost all patients. Abdominal or flank pain in about 3/4. Shock occurs in up to 30% of them, and acute kidney injury in 35%, with CNS involvement in about 1/5 of these patients. The left kidney, interestingly, is affected more commonly than the right, and underlying cystopathy, as it says here, predisposes to this condition. This is an ultrasound picture of emphysematous pyelonephritis. This is the normal pelvic fat, and you can see what appears to be hypertense shadows in the pelvis and to some extent in the parenchyma of the kidney. This is gas shadow. So gas appears white on ultrasound in an emphysematous pyelonephritis. And of course, the CT scan is what is used to stage this condition. Class 1, gas in the functional kidney or a transplanted kidney. This is a CT scan of a patient that we recently treated, and this is what has changed in the management of emphysematous pyelonephritis. This is the initial scan. You can see that the right kidney is virtually not seen. That's all the parenchyma that there is, and there is a large collection of gas in the renal fossa there. After 7 days of antibiotic treatment, the parenchyma has actually improved and the gas shadows have decreased. And after percutaneous drainage, this is a percutaneous drain, what you can see is there is a significant improvement in the parenchyma with only minimal gas, and some of that gas, I'm not sure if you can hear me, this is the gerotastation, some of that gas is tracking externally, so this is class 3B. Now, a few years ago, such a patient, I would say many years ago, 20 years ago, such a patient would have got a nephrectomy at diagnosis. But today, many of these patients are salvaged by conservative treatment. And this is the current recommendation that nephrectomy is only recommended if there is no access to percutaneous drainage or internal stenting, if there is gas in the renal parenchyma, like the first picture I showed you, but even this patient was salvaged. Class 3 and class 4 with more than 2 risk factors, that is AKI, organ sensory shock, or thrombocytopenia. All other patients would be managed by percutaneous drainage and antibiotics. This is an early nephrectomy specimen which we done, a nephrectomy 14 years ago in a patient. You can see that the kidney is completely damaged, there is virtually no parenchyma seen, and there are these microabscesses throughout. There is pus cell casts in the tubules that are preserved, and there is a dense infiltrate of polygonal nucleus cells. When we looked at about 20 of our patients, E. coli was found in 12, Klebsiella in 3, Citrobacter in 2, and 4 had additional candida. 10 of our patients made a complete recovery, 4 were lost to follow, and 3 recovered partially coming off dialysis but had some renal impairment. Another condition common in diabetics, xanthoplasmosis pyelonephritis, in contrast to emphysematous pyelonephritis, is a chronic infection. It occurs after recurrent, very minor symptoms of infection in patients, which often will sustain treatment, but the underlying pathology remains. Women are more predisposed, poor diabetic control predisposes patients. The organisms are typically low virulence as opposed to emphysematous pyelonephritis, where they are high virulence. A mass in the kidney is frequently palpable in this condition, and very often nephrectomy will be required in this condition, and the diagnosis is often confirmed by histopathology of the nephrectomy specimen. Malakoplakia, another condition common in diabetics. I have seen genital as well as urinary malakoplakia in a diabetic patient. The age again is in the 6th decade. Women are more predisposed than males. Again, low virulence organisms. Hematuria is a common presenting finding. Poorly controlled diabetes. So this is the key trend that runs through almost all infections. Poor diabetic control. Obstruction is uncommon as opposed to xanthoplasmosis where it is common. Masses are usually not palpable but found on imaging, and the diagnosis is typically made on histopathology by the classical Michaelis-Goodman bodies seen in the macrophages. Renal tuberculosis, the genitourinary tract is the commonest extrapulmonary site, and a more aggressive course has been noted in India and in diabetics. It has an insidious onset with fever, weight loss, and anorexia. Hematuria is common, and so are almost all urological findings. The polar regions, the upper and lower poles, are commonly affected. Mass lesions and masses may be seen instead of cavities which occur typically when the granuloma erupts into a collecting duct system. There is no leukocytosis in this condition, and culture by conventional engineering is the gold standard but takes about 6 to 8 weeks. And recently, we all use this. The nucleic acid testing PCR, either DNA or RNA based, has sensitivity of 70 to 100% and specificity of 80 to 100%. And it also, with the gene expert and the line probe assays, it also tells us about primary resistance to INH and inflammation. Fungal infections, also more common in diabetics, typically candida, but also invasive aspergillosis and mucormycosis. Sometimes these can mimic bacterial sepsis, may be very difficult to distinguish between the two. This is a sample, a nephrectomy specimen from a patient of mine who had multiple abscesses on imaging, but none of these could be aspirated at surgery, and so the patient was taken for a nephrectomy because of failure to dissolve. This appears to be, and it was first reported as a tuberculous granuloma in the nephrectomy Fungal walls, surgical removal and fluconazole. Prostatitis, surgical drainage with fluconazole. And amphotericin. I need to mention one last condition, and that is sterile pyuria. A large number of patients will come with recurrent sterile pyuria. Pyuria persists no matter what we do, and the cultures are negative. This could be because of incomplete urinary untreated UTIs, and the nucleic acid testing in this situation may still identify the organism. It's important to rule out gynecological infection, urethritis, prostatitis, viral infections where cultures will be negative. Cannot afford to neglect genital tuberculosis. And one more word about genital tuberculosis. Frequently, patients with underlying tuberculous cystitis, tuberculous urethritis will also have positive cultures with pyogenic organisms, and the tuberculosis may not be diagnosed unless it is specifically looked for if the clinical syndrome does not fit a pyogenic infection. Fungal infections, of course, bacterial counts will be negative, and then there are non-infective conditions. So, the presence of an inferior device, either a urinary catheter, a stent, urinary calculi, forgotten stents, fistula, interstitial nephritis due to drugs. We had drugs, and the patient's pyuria becomes worse because it's a drug-induced interstitial nephritis, papillary necrosis, and some group in which no cause is found. To treat these patients, there is no consensus. So, if I have to summarize, what does one do when faced with a recurrent UTI? The first principle, and one that could easily be achieved, good glycemic control. In elderly men and women, ensure that we rule out an obstruction. This is common, it is frequently not missed, and in this situation, the patient will have recurrent UTIs. Identify cystopathy and autonomic neuropathy. I have seen patients operated for presumed obstructions because the cystopathy has been missed, and this requires a careful neurological examination, including testing of the sacral sensations, the aerial reflex, and the bulbocavernosus reflex, which are normally not a part of our neurological examination. Search for and rule out gynecological infection in a woman. Eradicate reservoirs of infection. Prostatitis may require up to 6 weeks of treatment with susceptible infection antibiotics. Otherwise, this serves as a reservoir for recurrent urinary tract infections, more so in the diabetic, and a prostatic abscess may be drainage in this situation. Remove all foreign bodies. There is a reluctance to remove catheters frequently, and this is often a very difficult clinical decision. Keep constipation if present. This is something that can be missed, and if constipation is not treated, then the urinary tract infection will definitely recur. Identify tuberculosis, fungal infections, other non-pyogenic. Identify anatomic abnormalities. Provide bladder drainage. I showed you the study that we did in KM. There was a 50% improvement by providing continuous bladder drainage to these patients. Use the shortest possible antibiotic courses. Is there a role for prophylaxis? I think it has to be chosen as a last alternative when all the other things have been ruled out. And then, as I showed you in the slide on the antibiotic susceptibilities, choose a drug which is not going to be part of the therapeutic armamentarium. So, I typically would use, in a patient with normal renal function, we would use nitrofurantoin or cotrimoxazole only. I even avoid cotrimoxazole because there is a little bit of sensitivity developing to cotrimoxazole. Certainly not fluoroquinolones in this situation, and as I said, it is the last alternative to be chosen. Some time ago, single dose phosphomycin was being promoted as a treatment of cystitis. In view of the fact that phosphomycin, intravenous phosphomycin, is becoming an important weapon in serious complicated urinary tract infection, we should completely give up oral phosphomycin treatment for cystitis to preserve this antibiotic. Should every positive culture and pyuria be treated in asymptomatic? I think the jury is out on this. Identifying a single definite guideline after searching several bases on how to treat these patients definitely is usually after the revision. I will not treat asymptomatic pyuria and bacteria now, but I culture all these patients, and if subsequently the patient becomes symptomatic, that's when I would start treatment based on the previous culture. Thank you for